Welcome back to another episode of Figuring Out Fertility. I am Carolyn Dubé, Executive Director of Fertility Matters Canada. It is Canadian Fertility Awareness Week, and along your journey, if you're new to the infertility, if infertility is new to you, you may have had some questions about anatomy, your anatomy, especially female reproductive anatomy. We get questions about this all the time, and I'm thrilled to be here with you today. And Dr. Ari Baratz, who is a reproductive endocrinologist, fertility specialist, and also president of the board of directors of Fertility Matters Canada. Ari, Dr. Baratz, thank you so much for being here. I'm really looking forward to digging into this topic with you.
Well, thank you, Carolyn. It's always an honor to be one of the guest speakers during CFAW. Maybe the A in CFAW stands for anatomy, or maybe the A in Ari stands for anatomy. But I think it's a great topic because it's one of the topics that at any stage of one's journey, whether it's issues around fertility, dealing with infertility as one of the diagnostic factors, recurrent loss, and also may become a secondary issue. Someone may have not had fertility-based issues or recurrent loss issues, and then they're coming back to build their family, or they're in a new situation to build their family, and now they've acquired certain anatomic issues. So I'm happy to go in whichever direction you feel most comfortable. But I think maybe before we even start, we might want to just define or lay out beyond just this in the initial intro, where anatomy or how anatomy comes into play.
Yeah, that was going to be my starting point. So let's talk about that, because in our support groups, a lot of the questions that we see come in, especially for people who are brand new, who have just been diagnosed or have just seen their physician, and they've gotten this diagnosis or something's come up on a scan and they say, I don't even know what that means. Let's talk about anatomy of the reproductive health tract.
Right. So high level. So first of all, when we talk about building a family, making a baby, avoiding loss, usually anatomy is broken down into two big sub areas. Female assigned anatomy and male assigned anatomy. My comments are really mostly going to be towards the female based, and usually an OBGYN, gynecologist, reproductive endo and fertility specialist would be the one that would be working on identifying and or correcting those areas. Whereas on the male side, you might be seeking out a urologist or general surgeon. They might be the one that you would meet. And that might be actually ideas for other subsequent sessions to bring out a urologist to discuss their angle on this. But when I look at anatomy, I think about, is the anatomy something that someone was born with, or what we call a congenital finding? That's the technical term. Or is this something that was acquired? And there are various ways that one would acquire anatomical issues, either infection, trauma, through a delivery. And so when I discuss this with my team, I kind of simplify it into you got it or you get it. So you got it refers to things that you've already have pre-existing from the time that you were born. And when we know that anomalies or abnormalities of the female reproductive tract can occur, the instances all over the place, but probably anywhere from 1 to 10% of women, more on the reproductive side, people dealing with fertility or recurrent loss side, more of these anomalies will come up. Or you get it, meaning you acquire it. And acquiring it could be an infection. It could be developing certain structures like polyps, endometrial polyps, or uterine fibroids, or abnormalities with the fallopian tubes. And these are all buzzwords. They all come up whenever you talk about Fertility 101. About 20 to 30% of diagnoses include, or factors are included as anatomical. And so the first step for people, other than reading about it, is when they meet with their fertility or reproductive specialists, are having a history. So talking about how they came to the clinic, either as a first-time patient or after having a problem with a delivery, some type of surgical complication, or it will come up through testing. So it may be silent, meaning a patient might come meet me and say, oh, I'm totally healthy, Dr. Baratz. I went through puberty normally. I've never seen a gynecologist before. In fact, you're the first doctor I've ever really spent time with, because other than maybe having my well woman checks, I haven't really had to see somebody. And then we do tests, and then we diagnose these anomalies.
So when someone is coming to you, there's two reasons that they likely would come for these checks: because A, they can't get pregnant, or because they've had sort of maybe a conversation or some testing done with their family physician and something has come up?
Yeah. So first of all, as part of a primary or secondary infertility workup, as well as part of a primary or secondary recurrent pregnancy loss workup, or early fetal loss, they would be subjected to a number of anatomical based studies. And that typically includes ultrasound is the main modality, but even before ultrasound, there might be a physical exam focused on the pelvic exam, ultrasound, and then beyond ultrasound, there are higher level imaging that we have. We have office-based surgical procedures with what's called a hysteroscope, which is actually a little camera that can go up inside of the reproductive system to check the uterus. With ultrasound, we have a more provocative test called a sonohystogram or a sonogram, which uses either contrast or fluid to further elucidate the upper reproductive system, so the cervix, uterus, fallopian tubes. And then there are even other more fancy tests like CAT scans or MRIs that you may have heard about in other areas of medicine, but they can be targeted for either pelvic anomalies that were there from the beginning, or like as that term I said, you got it, or the anomalies that you get over time, whether they're fibroids or polyps or other structural abnormalities.
So if you're a patient and something comes up, say you have a structural abnormality or something with your anatomy that might not be quite perfect, does that mean you will have trouble conceiving? And if you do have trouble conceiving, will you be able to go forward and potentially carry a pregnancy? What are some considerations
Right.
for?
Right. Well, that's a great question. You're a great interviewer. Those are amazing questions.
Thanks.
So the first question is, and I refer to that as clinical correlation. Is this thing significant or not? So we meet people here, both men and women, who will come to the clinic, and they will come with an incidental finding, meaning someone did an ultrasound for whatever reason, not fertility based, not recurrent loss based. They just happened to have a scan because they're having abdominal pain, and someone identified that they had a fibroid. Similar finding, fibroid, but this patient is now patient number 2 is presenting, has had 2 miscarriages, had an ultrasound along the way. We did some imaging, and we also found a fibroid. So in patient A or patient number 1, the incidental fibroid may or may not have any relevance to their future fertility. Maybe they haven't even been trying. Scenario number 2, or the B patient, they've actually been trying, they've actually experienced loss, and now we have to correlate this and put this fibroid into context. Now, I mentioned fibroids because they are super, super common. And by the way, all of these more technical terms that I'm mentioning, they each have FMC tox attached to them, right? They each could be tox. But speaking about fibroids, because they really are one of the more common anomalies, these are typically benign growths of the muscle layers of the uterus. And they have as much as some have described an almost 80 to 90% incidence in women in general. So they're very, very common, right? But we're not seeing every single female with a fibroid in them. We're only seeing a select group. And so the fibroid issue really comes down to its location, where exactly the uterus is placed. You may have heard of what's called a submucosal fibroid. So if that's identified, that's typically amenable to surgical correction, either in the office or in the hospital. And that would be offered for either infertility-based issues or recurrent loss issues. Where it becomes more tricky is if it's identified as an incidental and someone hasn't had either of those conditions. They haven't had a loss, they haven't really been trying. And that's where you really have to put it together with other factors that have been going on. And all my comments really need to be put up against your own specific case with your own provider.
Yeah.
But what I would say is that most of the anomalies that we identify, or a large percentage of them, are amenable to correction, and most women will be able to conceive in spite of them or with assistance. What's tricky are some of the anomalies that are not amenable to correction, or despite correction are still present.
Mm.
And so, for example, there's a type of malformation called a bicornuate uterus. So the uterus is typically a solitary structure, but during its development, it actually starts as two substructures that merge as two separate tubes that unify to become one womb. And so if along that unification, something is interrupted, you end up with two hemiuteri, or two smaller uteri. That's something that currently we don't have surgical corrections for. We provide encouragement. That kind of person would actually want not just infertility evaluation, but also obstetrical evaluation in advance. And they would be entering a high-risk pregnancy. Many women like that will be successful, but some won't. And if they're having trouble, they may need to see someone like me to discuss options, either of selective fertility treatments or sometimes even surrogacy in cases like that.
How often is that? It's something that it pops up every now and then in conversations. We see it. What's the relevance or prevalence, I guess, of that? Do we know?
Well, Mullerian anomalies, so, malformations of the female reproductive tract, occur at an incidence of around somewhere around 1% to 10%. It depends on which population, which study. I think there's many of them that go undiagnosed.
Mm-hmm.
I'll never forget being a resident and doing a cesarean section, like an operative delivery, and examining the patient's anatomy and noticing that there's a really abnormally shaped uterus there, but yet the patient did really well other than having the C-section. And then I've met people where despite multiple efforts, they're not able to conceive. So I would say that it's somewhere around 1 to 10% of people have some kind of anomaly. The deeper question is, what percentage of the anomalies require surgical correction, and what percentage of them are actually amenable? And that, again, is all over the map. And also some of them don't even fit classification, right? So some anomalies are actually placed into a surgical correction space,
Mm-hmm.
where either a gynae surgeon, OBGYN, or REI would correct them, or they're in the non-surgical space. And that's a bit of a nuanced answer. But I would say that if you are identified with an anomaly, you should probably get a higher opinion, maybe even MRI, to properly classify, because what you don't want to happen is you don't want to be that person that gets operated on when they shouldn't have been operated on, or not have the procedure when they should have had the procedure.
Yeah, that's really good advice. Okay, so we've got the uterus, we've got growths, we've talked about fibroids.
Right.
What other anatomical issues could the female reproductive tract come up with?
I think another one in terms of the acquired, I mean, again, all of these have other examples that we've glossed over, but another common one are fallopian tube findings. So the fallopian tube is a structure that typically women are born with a left and a right fallopian tube, and they communicate between the uterus and the ovary, and they are the conduit for the egg and sperm to connect. So in normal reproduction, an egg is ovulated from the ovary, it floats down the fallopian tube, it rests in the fallopian tube, waiting for sperm to make their way also into the fallopian tube, and that is the setting for fertilization and early embryo development. And so fallopian tubes need to be patent, so they need to be open. And all you need is one fallopian tube to conceive. You can have a right side that was either removed or not working. But interestingly, if a fallopian tube is not functioning properly, if it's dilating with either blood or pus or fluid, it becomes a liability. And those tubes need to either be corrected and or removed. And we call those hydrosalpinx in the form of a fluid, pyosalpinx in the term of pus filling the tube, or hematosalpinx, which is when blood fills the fallopian tube. And so that's an area that, again, requires opinion. It may require surgery even in advance of trying. It may require surgery after a failed attempt. But there's definitely been linkages between those type of fallopian tube abnormalities and difficulty conceiving, failed implantations, and maybe even recurrent loss. So that's another area that shows up on ultrasound and then typically takes people down an evaluation and or surgical pathway.
Great. And then I'm probably missing some sections, but I feel like the next obvious step is the ovaries.
Yes, the ovaries. So a distinct organ.
A distinct organ.
The ovaries are on their own. They're part of the reproductive system, but they're separate from the fallopian tube and the uterus. The ovary can also be amenable to incidental findings, like an ultrasound can be done for a variety of reasons. Remember the abdominal cavity, which is everything from the just below the rib cage all the way to the underwear line, like that whole space is considered the abdominal pelvic cavity. And there are many reasons why people would have that area imaged, either because of gynecologic issues, non-reproductive issues, gastrointestinal issues, urinary issues, musculoskeletal issues, and invariably the ovaries come into the field. They'll be picked up, and you'll see them on either on ultrasound or CT or MRI, and then maybe there'll be a finding, and the most common would be a cyst. And then the cyst has to be classified. Is that cyst a benign cyst, or is it a cancer-causing cyst? And in the case of fertility, is it a cyst that is associated with other reproductive issues like endometriosis would be a classic example. Or is it not that there's one cyst, but there's a bunch of tiny cysts? Is this a polycystic appearing ovary? So it's interesting how anatomy can lend itself to diagnostic clarity. And then that can lead one down a certain path of treatment. So some of the things that we just mentioned on the ovary require surgical treatment. Some of them require surgical consideration, and some of them are just glossed over. Like for example, a 2 centimeter mid-cycle cyst on the ovary that's simple in nature will just be observed, and it's probably just where you're ovulating from that month. Whereas if someone has, let's say, a 10 centimeter complex cyst, that might be evaluated to rule out any malignant features, and that might end up with a surgery.
So for people watching, if they're interested, like, is an anatomy workup a thing when or if along your journey? You may not even be, I guess, at the stage of thinking about having a family. You might not have a partner. You want to start your family. For people with the ovaries and the uterus, how or at what point should they consider having an assessment? Should they consider having some sort of scan? Or is this something that until an issue presents itself, you kind of leave it alone?
Yeah. Well, I think that's really one of the takeaways for this conversation is we don't want to overinterpret findings. We also don't want to underinterpret. So I would say that most of this lays dormant and silent, like it's something that you're not typically aware of. If you were growing up and your doctor said, look, you should see a gynecologist or urologist in the future because there's something there, but it's really fertility based, then I think when you're ready to start a family, you should pursue it and request at least an ultrasound or an examination to see if one is warranted. If you're someone that was born with uterus and ovaries and are going through a transformation or going through transition, I think you should ask about future fertility and if there's a role for preservation. So I think it starts with questions. And then finally, if you do find yourself in a space where you have been trying and it's not working, don't be shocked when your provider says to you, I think we should take you through a deeper dive into tubal patency testing, uterine cavity assessment, sonohystogram, sono-HSG, pelvic ultrasound, maybe even MRI. And it's not to instill fear, but it's actually to instill confidence that you are okay, or if you're not, these are areas that could be corrected. And what's interesting about anatomy is it's concrete, like we can see the anatomy. And maybe it's because we're simplistic in our approach, but if we can see it, we typically can adjust it or treat or consider it for treatment. And so it's one of the more common areas that will be looked at. Another cautionary note is that the deeper the anatomical dive, these are uncomfortable tests. And so I always tell my patients when I meet them, I always apologize in advance and say, look, I'm sorry. Some of them are uncomfortable. There may even be an option to have these tests done under sedation if one is worried. So, again, if someone is coming in with virginal status or has a history of dyspareunia or pelvic pain, they don't need to be tough and bear these tests. They should describe their pain and their concerns, and their provider should be able to find a way to either do this under sedation or find alternative tests that are less comfortable. So I think it fits under advocacy as well. I mean, we live in a country that is very advanced, but access to these advanced tests may not always be available. So it's these kind of sessions that wake people up, both on the patient side and on the provider side. And also to always ask why. Why are these tests being done? So those may allow you to be more motivated to have them done, or maybe they can be delayed, maybe they can be deferred if they're not required.
That's really good advice. And you're right. We live in this country where access to sometimes even a primary care physician is really not available for people. So that becomes, more of a barrier. I know some of these issues, these anatomical issues can stem from things that potentially could be preventable. For example, maybe an STI. Can we talk about considerations for people, and maybe it's for a younger generation of people, things that maybe lifestyle factors that potentially could impact, so that we, as we're making decisions through our life, just things to consider,
Mhm.
that decisions we make could impact our future fertility.
There's no question that some of the decisions that you make and the high or low risk behavior that you take at a younger age may have impact for future fertility. You used sexual transmitted infections exposure as an example. I think that's a great example. Typically, when people are in their teens or early sexual experiences, are not really thinking along the lines of future fertility, or it may not be front of mind. And there's definitely a high incidence between exposure to STI pathogens and future tubal issues. We know that there's a rise of smoking in our community and younger people, and that can also have impact as well. There's alternative types of contraception. More and more women are using IUDs, intrauterine devices, which are great for contraception, but they really still leave exposure to STI transmission. Sometimes that message is not coming through. Similarly with the birth control pill, great at blocking pregnancy, but not so good at all, not effective at all at blocking STI. And the other issue too is that sometimes women, I speak about women because I am not a urologist, but there may be an equivalent in the male situation. But sometimes women are having gynecologic issues, either with pain or regular cycles, and they are faced with the situation of either having to go on medication or have surgery. And sometimes these early maneuvers, are leading towards downstream complications. For example, they may have had a cyst that was operated on aggressively, and they may have lost an ovary. And they have that knowledge, and that's not just an anatomical consideration, that's also an ovarian reserve issue. But what I'm getting at is that something happened earlier in their lives, and they waited too long to start thinking about fertility preservation or building a family. And had they sort of held on to that bit of their medical history, maybe they would have sought attention earlier. So my take home on that is be aware of your health, be aware of your decisions, and keep a little tally, a little log of what you've been through. And when you do hit that, your sort of college years, 20s, late 20s, early 30s, maybe see a fertility specialist to discuss fertility preservation, and some of these anatomical considerations may come up as well.
I think that's really good advice. I'm seeing more and more through social media. In fact, we've had a few interview requests come through our office to talk about fertility preservation and egg freezing for young people. And I think this generation of younger people, what might sort of anecdotal from what I'm seeing, is they are more actively, they're seeking information about all kinds of different things and collecting that information earlier. And I really appreciate you being able to say that, you can have these conversations with your, maybe it's a fertility specialist, maybe it's your family doctor, if you've got a good relationship there and you know that they're going to help you sort of talk about your future family planning. If you're a young person and you want to travel and you want to finish school and you want to work for a few years, by the time people are starting their families in Canada, at least, they're in their early 30s now. And so some of these issues that may have always been there or may be a result of something else. If you're having those sort of fertility conversations or fertility workups, or at least a consultation to talk about what your options are, these are things that could come up early, so that when you eventually are ready to build your family 5-10 years from now, it doesn't come as a surprise. There may have been something you could have done earlier to help um, with getting pregnant or conception or carrying a pregnancy in your later years.
Agree. I think another area that you struck to mind, because I keep looking at the Canadian Fertility Awareness Week logo on the screen. Awareness comes in different forms. We normalize a certain pathway for fertility with a lot of assumptions, but there are many routes that people take, and I think awareness, sexual education, it starts early on, but it doesn't start early on for everyone. If you're in a more conservative environment, maybe a more religious environment, there may be a gap in knowledge on just how basic anatomy functions. We make a lot of assumptions about how long people have been trying, but sometimes even the mode of intimacy, the mode of intercourse, may not be properly appreciated or understood, and that leads to education. That's anatomy as well, and also people being comfortable with their anatomy in the face of previous either assault or abuse, and those people have the anatomy, but the anatomy may not be available to them because of psychological barriers, trauma, PTSD. So that might be the entry point. People may have very deep mental illness or PTSD, and their anatomy just may not be accessible to them, even if it's totally normal, because of this that issue. So again, heavy work with the counselors. The anatomy becomes the handle, and it's a very interesting topic. I think it gets glossed over quite a bit, and either over or under interpreted. And I'm always happy to talk about it. I know you're very active on direct messaging. Always happy to help triage any of the questions that people have about their anatomical considerations. And I think that out of this talk, there should be a needs assessment on the anatomical foci, like a talk on fibroids, a talk on polyps, a talk on septa. These are all conversations about anatomy that we're lucky that we have ways of treating many of these things.
Yeah, such a great. I've been writing down notes here as you've been speaking. For those of you who don't know, we do have a podcast called
Fertility in Focus.
Fertility in Focus. I apologize, because this webinar series is called Figuring Out Fertility. So the FIFs sometimes get interchanged. And I'm writing down some topics here that, of course, we'll ask Dr. Baratz back for, and some of our other fertility experts, because these are key messages that need to be made public, and we need to have them made more accessible so people can access them to get the information they need. Fertility care in this country is not that accessible to everybody, whether that's because of a financial barrier, a geographical barrier, an education, an awareness barrier. So that's part of the work that we do at Fertility Matters, to drive these awareness sessions and to advocate for better access and better education, so people are more comfortable making these choices about their reproductive health.
Well, I was going to follow up that saying, and we're very fortunate in Canada. Like, let's take, for example, one other finding, which is called Asherman syndrome, or adhesions of the uterus. We're very fortunate that we have quite a bit of access to care in the main centers. And then we have also ways of escalating. We have some of the world experts in some of these areas. And so, like in my practice, I'm a referred to physician. I handle a lot of these cases. And if the case is too complicated, then I have other providers that I can work with, either in collaboration or in referral. And then, look, sometimes these anatomical considerations will need to be further escalated in a different direction. So we mentioned surrogacy. Like, there's an answer for all. If we can't fix the anatomy, we can sidestep the anatomy. And so find the right fit for you, find the right provider team, make sure you're looking at the right research and the right information. And I'm happy to leave with any final thoughts. Or do you have any final thoughts?
No, I was just going to ask you, sort of, to wrap things up, your top sort of 3 takeaways, but those might have been it.
Well, the top 3 is, make sure you figure out, is this congenital or acquired? Like, meaning, have you always had this, or is this something new? Make sure that whatever this condition is properly understood and identified before any intervention. And number 3 is be open-minded with interventions. meaning make sure that you're comfortable with your team. If you need a second opinion, seek that out. But be prepared for the opinion that you're given.
Yeah, that's great advice. I love the idea of having an open mind. And if you are seeking a second opinion and you aren't sure where to go, please reach out to the team at FMC, and we're happy to help connect you to a team of physicians across the country who may be able to provide that for you. Dr. Ari Baratz, thank you so much, as always, for your time today. This is Canadian Fertility Awareness Week 2023. A reminder, Fertility Matters Canada is a registered Canadian charity, and if you have the ability to donate to our charity, you can do so by visiting fertilitymatters.ca. We hope you enjoyed this session, brought to you with the generous support of Ferring Pharmaceuticals.